What is going on, wonderful people? Welcome to this explainer. We are jumping right into the deep end today, untangling the massive web of adrenergic antagonists. I know, neuropharmacology can absolutely feel like trying to drink from a fire hose while reading a foreign language, but we're bringing high energy, pattern recognition, and crystal clear logic to make this actually stick in your brain for good. No nonsense, just pure, high-yield understanding. We're going to discover these patterns together. Let's do this.
Honestly, we've all been the confused neuron at some point, right? Just staring at pharmacology texts until your brain literally feels like scrambled eggs. It's incredibly frustrating trying to memorize 100 different drugs that all sound exactly the same. But here's the secret. Medicine makes perfect sense once you understand what the flip you're actually looking at. We aren't going to just brute force memorize things today. We're going to learn the patterns. By the end of this, that confused neuron is going to be a bona fide pharmacology genius. So, let's set our crucial baseline, sympatholytics. Basically, these are drugs that bind to adrenal receptors but do not trigger the usual receptor-mediated intracellular effects. They're the ultimate blockers. They just sit right there on the receptor and prevent activation by your body's own endogenous agonists, like norepinephrine or epinephrine, or even exogenous ones you might give a patient. Essentially, think of these as your anti-fight or flight agents. They just shut down the sympathetic nervous system right at the receptor level.
To keep your mental map totally organized, let's split this pharmacological world right down the middle. On one side, we have the alpha blockers, on the other side, the beta blockers. Just like the agonists we've talked about before, the antagonists are classified according to their relative affinities for alpha or beta receptors. Having this clear division in your head before we dive into the weeds is going to save you so much grief.
The alpha strike. We are talking about the alpha adrenergic blockers. Let's get into it.
Okay, time for some suffix mastery. If you are memorizing these drugs one by one, you're just making it way too hard on yourself. Learn the pattern. The golden rule for selective alpha-1 blockers is the osin suffix. Say it with me. Doxazosin, tamsulosin, alfuzosin, silodosin. If you see osin, you should instantly be thinking selective alpha-1 blocker. Pattern recognition is literally how you survive pharmacology, so don't be an amateur and try to memorize them without the rule.
What's really fascinating here is the sheer contrast between old-school and highly targeted drugs. Take phenoxybenzamine. This is a non-selective, actually, scratch that, it's a non-selective, irreversible, non-competitive blocker. It binds so tightly that your body literally has to synthesize brand new receptors just to overcome the block, which takes a day or more. That's exactly why its action lasts about 24 hours. Now, contrast that with doxazosin. It's highly selective for alpha-1, it's the longest acting of its specific class, and here's a totally wild clinical pearl. While most of these drugs excrete their inactive products in the urine, doxazosin actually gets excreted in the feces. Crazy, right?
Now let's build a rapid-paced logical sequence. I love this rule. Say what you write what you say. Alpha-1 blockade equals vasodilation. Normal sympathetic control of your vasculature happens largely through alpha-1 receptors. So, if you block them, you reduce that sympathetic tone. The blood vessels just relax. Boom, vasodilation.
Let's see how this builds. Again, write what you say. Vasodilation equals lower blood pressure. When those pipes open up and dilate, the total peripheral vascular resistance drops. And when resistance drops, your blood pressure absolutely plummets. It's just basic physics applied to the human body. And here is the punchline of our sequence. Lower blood pressure equals reflex tachycardia. You see, the body is a highly tuned machine. When it senses that sudden, profound drop in pressure, it essentially panics. The reflexes kick in, and the heart speeds up to try and compensate for the loss of pressure. Result? Reflex tachycardia.
Now here's the real aha moment. Knowing that sequence tells you exactly what the side effects are going to be. Because you're dropping the blood pressure and causing vasodilation, patients will naturally experience orthostatic hypotension. That just means when they stand up quickly from a chair, the blood pools in their dilated leg veins, their brain momentarily lacks oxygen, and they get super dizzy. You also get that reflex tachycardia we just talked about, headaches from dilated cranial vessels, and sexual dysfunction. The physiological mechanism perfectly predicts the side effects. It's like a giant puzzle coming together.
Section 2, the beta blockade. Let's shift the momentum entirely and reset your focus. We've crushed the alpha blockers, so now it's time to tackle the beta adrenergic blockers.
Back to suffix mastery. The golden rule for beta blockers is OLO. Propranolol, Metoprolol, Atenolol. But hey, medicine wouldn't be medicine without a few exceptions, right? Don't let your exams trick you into forgetting the two rule breakers, labetalol and carvedilol. They don't end in olo, but they absolutely belong right here in the beta blocker family.
Now, this concept right here is arguably one of the absolute most important things to grasp, the difference between non-selective and cardioselective beta blockers. Non-selective drugs like propranolol block both beta-1 and beta-2 receptors. Cardioselective drugs like metoprolol, atenolol, and sympatholytic preferentially block beta-1 receptors. Why does this matter? Well, beta-1 is in the heart. Beta-2 is in the lungs. If you give a non-selective beta blocker to an asthma patient, you're blocking the beta-2 receptors in their lungs, causing severe bronchoconstriction. You'll essentially trigger an asthma attack. Give me a break, right? If you forget this clinical pearl on the wards, your attending is definitely not going to be happy, and you'll be the one needing an inhaler.
The clinical uses for these are just massive. Beta blockers are incredibly versatile. By blocking beta-1 receptors in the heart, they decrease heart rate, contractility, and overall cardiac output. They are essentially putting an overworked, stressed-out heart on a much-needed beach vacation. This reduces myocardial oxygen demand, making them incredible for angina, arrhythmias, and protecting the heart after a myocardial infarction. They even treat heart failure, hyperthyroidism, glaucoma, and can be used for migraine prophylaxis. The whole shebang.
Section 3. The Rogue Agent, Reserpine.
Okay, we've covered the competitive antagonists. Now we're taking a slightly more dramatic turn. I want to introduce you to a strange, old-school drug that acts totally differently, reserpine. It's a plant alkaloid, but it doesn't just sit on the receptor like the others. It acts like a thief. It blocks the magnesium and ATP-dependent transport of biogenic amines from the cytoplasm right into the storage vesicles inside the adrenergic nerve terminals. Basically, it sneaks in and totally depletes the nerve terminals of norepinephrine, dopamine, and serotonin. It just empties the entire tank. Because it empties the tank, its characteristics are super unique. It has a slow onset and a very, very long duration of action, mainly because it takes days or even weeks for the body to replenish those depleted vesicles. But here's the serious clinical reality of why we rarely use this drug for hypertension anymore. When you chemically deplete all of a patient's dopamine and serotonin, their happy chemicals, you can induce severe clinical depression, even to the point of suicidal ideation. It's a fascinating mechanism for sure, but the reality of those side effects is just incredibly harsh. All right, to wrap up our explainer today, it is pop quiz time. Let's test that retention. Based on the patterns we learned today, which selective alpha-1 blocker ending in our famous -osin suffix is famously indicated for the treatment of benign prostatic hyperplasia, or BPH? Think about the drugs that target those smooth muscles. I'll give you a second. You guys have absolutely crushed this material today. Take these patterns, take this logic, and go totally dominate your next chapter. See you next time.